Yeah, good morning, everybody. I would like to thank dear Diabeticon for giving me the opportunity to speak on. So today I'll be speaking about management of chronic coronary syndromes in patients with diabetes. So, yeah. So what we have to understand is that the link between diabetes and cardiovascular disease is as strong because it's very strong. It increases the risk of coronary artery disease by more than 2 times, 2 to 4-fold. And we see that around 80% of the patients with diabetes die from cardiovascular disease, mostly ischemic events. Therefore, the challenge is to detect and manage these patients with who has a very significant disease, very important. This So what we have to understand is that the complex association between diabetes and CAD may explain why it is still difficult to optimize cardiovascular risk in patients with diabetes. Insulin resistance is a hallmark of type 2 diabetes, we all know, which leads to anemia, which is a part of that metabolic syndrome. What we see is that patients with diabetes have the chances of having low HDL, that is less than 10% of the population is very high, and also more than 50% are likely to have hypertriglyceridemia. And also because of the obesity and also because of the advanced glycosylation end products, the diabetic patients have higher level of both subclinical inflammation as well as they tend to develop endothelial dysfunction early, and which is very predominant. So this combination of hypercholesterolemia, inflammation as well as endothelial dysfunction, what we call as a triad, are the key mechanisms for the initiation and progression of atherosclerotic coronary heart disease. So as we see, it's primarily caused by deposition of atherosclerotic plaques in the heart. So whenever we call coronary heart disease, we divide classically into two syndromes. One, what we call as acute coronary syndromes. The second is chronic coronary syndromes. So what we have to understand is that CAD is a very dynamic. It ranges from asymptomatic to symptomatic, and also the pathophysiology presentation also varies accordingly. So, to simplify the management and how to take care of that, we usually classify them into either ACS and CCS. ACS is a simple thrombotic occlusion causes ACS. CCS again, but it's a complex entity. So, in practice, CCS spans a wide spectrum of possible clinical presentations. It is defined by the different evolution phase of CAD, excluding the situations in which acute coronary artery thrombosis dominates the clinical presentation. So, no thrombosis, the conditions all are chronic coronary syndromes. So the spectrum can be anything. Usually we classify them into 6 categories. One, patients with suspect CAD and stable angina symptoms and or dyspnea. Second, patients with new onset heart failure or left ventricular dysfunction and suspected CAD. Third, could be asymptomatic patients who are routinely diagnosed on screening or routine investigations. Fourth would be asymptomatic and symptomatic patients with stabilized symptoms, that is, they had ACS, they are stabilized, but the duration is less than 1 year. Similarly, the fifth group is asymptomatic symptom patients who are stabilized, but the duration is more than 1 year. And patients with angina suspected vasospastic or microvascular disease. So this trend shows that chronic coronary syndromes are not a simple, straightforward entity. They are a heterogeneous group of disorders. Apart from the ACS, the rest of the things are chronic coronary syndromes. So these are classified as, but also we should understand that these are at different risk profiles. Patients have different risk profiles and are at a different risk for future events. So we should say that when we take cardiac disease, CCS forms a major component when they compare with acute coronary syndromes. Therefore, managing this would become a very, very, very important thing. So what we should understand is the diagnosis of chronic coronary syndrome is a stepwise process, which includes just clinical presentation, symptoms, various lab parameters and all those things. I'm not going to those details as of now. And important thing is that to diagnose this thing, coronary imaging is needed. Mostly we prefer to do non-invasive, which includes treadmill tests, stress testing, calcium scoring, coronary calcium, coronary angios. Sometimes in patients who are very much high risk profile, very much symptomatic, probably invasive angiogram is advised in these setups. So what we should understand is that why managing CCS is very important, because we are seeing now patients getting affected at very younger age groups. We are considered as a diabetic capital of the world and probably the diabetic capital of India. So we tend to see more patients getting enrolled earlier, diagnosed with diabetes and presenting with coronary artery disease at early ages. So with increasing technology and probably awareness, strokes, MIs and amputations, peripheral vascularies have decreased. But we have to understand that morbid ischemic, that is chronic coronary symptoms, are steadily rising. So we have to regroup and refocus so that these things are addressed, because even though these are chronic coronary syndromes, they have a significant effect on the mortality and morbidity, and also probably affecting the younger generations, which are the important workforce of the country. So how do we manage these things? So the next few slides will discuss about management of chronic coronary syndromes. So we are discussing chronic coronary syndromes in diabetics. So being diabetics, the most important thing is that how do we manage hyperglycemia, glycemic control in these patients? Does glycemic control in a coronary CCS patient does differ from other patients, other diabetic complications? For several decades, diabetic guidelines have gone for strict controlled blood glucose with a targeting of HbA1c 6 to 0.5. But the risk reduction could be achieved by clinical focus on reaching target values of HbA1c as per the strategies. But three major clinical trials, which is the cardiac, have showed that even though strict HbA1c or the strict hyperglycemic was helping in taking care of the microvascular complications, but they did not show any reduction in major cardiovascular events compared with less intensive glycemic control in patients with type 2 diabetes mellitus. So if you go for the UKPDS Accord, which are the major studies, they showed that okay, HbA1c of 6 to 6.5 have prevented microvascular complications, but when it comes to macrovascular, predominantly cardiovascular, they didn't show any benefit when HbA1c 6 to 6.5 was compared with HbA1c around 7. And also several cardiovascular outcome trials says that okay, irrespective of glycemic control, also the type of drug which is used to advise or take can also made a difference. So not only the level of glycemic control required cardiovascular is different from the routine management, it also showed that different drugs behave differently for the same glycemic control as we consider the cardiac control. So this evidence is shifting our previous glucocentric approach of diabetes towards to considering the actual mode of how do we actually control the sugars. So if we see that in a patient with chronic coronary syndromes, what would be the ideal glycemic range which we should take? So if the patient is young and the life expectancy is beyond 10 to 20 years, what we ideally advise is that HbA1c should be less than 7%. But contrarily, patients who are older, whose expectancy is less, and also who are at very high risk of hypoglycemia due to various other factors, could be due to CKD, could be due to other comorbidities. In this, the target is between 8 to 8.5%. So these guidelines are based upon the UKPDS Accord and also the various trials otherwise seen. What they have seen is that especially when it comes to coronary care, hypoglycemia also played a major role in worsening the symptoms or worsening the complications, because less than 1% hypoglycemia evidence instances has always put these patients at a better route. So probably for them, rather than the strict control, probably average control would be preferable in these patients. And also when we come to diabetic medications, so different medications, as we're discussing, have a different roles. Probably some are cardiac specific cardiac protective, some are cardiac neutral, and some harmful to the cardiac. So when we take these things, metformin comes, which is the first line among most things. Cardiovascular benefit possible. The evidence is low quality, but our clinical experience and probably the usage through years has shown that it's definitely cardiac safe and probably is a first line of therapy. And also we don't have any associated weight gain, or hypoglycemia is also very less common with morphine. So it becomes an ideal candidate for a patient with a cardiac. Similarly, SGLT2 inhibitors, these are the newer generations and probably are the most cardiovascular beneficial drugs which have been seen. So these have been approved that not only in diabetic patients, even for heart failure patients, these are being now proposed. Similarly, GLP-1 receptor agonists also have a cardiac benefits. Thiazolidines have some cardiac benefit, but also we should be careful when using with heart failure patients. DPP-4 inhibitors, neutral effects on cardiovascular outcomes. important thing is that they don't have weight gain or hypoglycemia. Insulin sulfonylureas would be the later ones because they have weight gain, they have hypoglycemia. So when and beyond this the sugar control is not good, probably this should be involved. Similarly, next comes hypertension. So hypertension is usually seen in, if you see the prevalence hypertension in diabetes, type 2 diabetes mellitus is more than twofold, and also most of the diabetic patients, that is around 70 to 80%, will have hypertension. Both presence of, I'm audible. Yeah. So both hypertension and diabetes increase with age, and also the prevalence increases, so thereby doubling or tripling the mortality and morbidity. So most of the epidemiologic observations is that there's a progressive increase in microvascular and macrovascular events. Post blood pressure is 115. So ideally, in these chronic CCS patients, our target would be to be less than 140/90, and especially with high risk factors such as previous stroke or neurological problems. CKD, we target as 130/80. Similarly, what we should understand is that similar to hypoglycemia, hypotension also has a major cardiovascular mortality morbidity, because patients who have a significant angina or ischemia, they go to hypotension less than 120s or 110s we have seen. Probably the ischemia will increase. They might land with infarctions. They might land with myocardial dysfunction. So probably controlling of hypertension is important, but also see to that the patient doesn't go into hypotension is very, very, very important in this sort of patients. The first line would be ACE inhibitors and ARBs. Similarly, long-acting thiazide direct is also very good. Calcium channel blockers are good, but also we should remember that calcium channel blockers should be sparingly used when there is LV dysfunction. Aldosterone antagonists, especially when you have some amount of LV dysfunction, because they have modulatory effects. Beta blockers. So what we should say that beta blockers, when we consider chronic stable angina or chronic coronary syndromes, beta blockers have a limited role to play when we consider stable CAD. They have mortality benefits in AMI, they have mortality benefits in heart failure, they have mortality benefits in acute coronary syndromes. But when it comes to treatment of hypertension in CCS, beta blockers have a lower role to play. So beta blockers reduce myocardial oxygen demand, are often considered a part of optimal medical therapy for all patients with CAD, but this is for anginal control, not for blood pressure control. So beta blockers should be only considered for blood pressure control if the patient is not completely controlled on other medications, and probably we need to have some rate control or some other things are there. So for the indication of stable coronary arteries in the absence of left ventricular deficient, beta blockers have not been shown to reduce the risk of mortality or MI. Furthermore, the benefit of long-term use of beta blockers after myocarditis has been questioned, with the best evidence showing that at least limited to only first 30 days. Thus, beta blockers as antihypertensive should be targeted to patients with clear indications such as angina, or to those who require additional blood pressure lowering beyond other agents. And it's better to select those with vasodilators such as carvedilol, levodopa, or nebivolol, ideally, rather than the originally preferred metoprolol or atenolol. So other strategies for blood pressure, this becomes very important: weight loss, healthy diet, reduced intake of dietary sodium, increased dietary potassium, physical activity and moderation. So each has its own benefits. Weight loss and healthy diet has shown a very significant help in controlling the blood pressures. Similarly, physical activity, which needs to be equally given important. Comes to the third important, dyslipidemia. Diabetic dyslipidemia is a unique one. Basically, we have more triglycerides, low HDL and high LDL. The worst thing is that even though the LDL levels of diabetics and non-diabetics is comparable, but because of the persistent hypertriglyceridemia and because of oxidized LDL, so this LDL is low dense LDL and also very much oxidized. So these, even though the levels are the same, the patients are at much more risk compared to non-diabetics. So how do we target patients of chronic coronary syndromes with dyslipidemia? The present recommendation is that even for diabetics, even with coronary, without any CAD, whether it's a chronic or acute, we advise at least moderate statins. So if patient has chronic coronary syndrome, always moderate to severe intensity with a target of less than 70 of LDL. In some certain centers, it probably will be targeting up to 55. So what the most important thing is that atherogenic lipid such as hypertriglyceridemia, low and small dense LDLs are the major parameters. So high intensity statins are the cornerstones of lipid therapy. And For those patients whose LDL is not controlled, with cholesterol is not controlled, even on high dose statins, or for those whom statins, probably high dose we can't reach because of side effects or some other profiles, estimate and PCSK9 inhibitors have been advised, and these have shown to be clinical benefits in most of the trials. There is no role in niacin, especially even for the hypertriglyceridemia. Fibrates are recommended only if the triglycerides is more than 500. Yeah, but any recent study which has showed that icosapentaethyl has helped in decreasing the triglycerides, also probably has decreased the mortality and morbidity and probably symptomatic relief in patients. So for present recommendation is that anybody with triglycerides between 135 to 500, probably not controlled on adequate statins and other these things, probably we can use icosapentaethyl. Beyond 500 still not controlled, the recommendations go for fibrates. So as important as control of LDL, control of triglycerides and non-HDL cholesterol also is very, very, very important. Coming to the antiplatelets. So chronic coronary syndromes, the patients mostly probably would need to be on some amount of antiplatelets and antithrombotics. Among the factors contributing to elevated cardiovascular patients is generalized prothrombic state due to altered coagulation and platelet function. Both are hyperglycemia and hyperinsulinemia alter the endothelium, and also the platelets are also dysregulated. So both of these things are a dangerous combinations. So we have multiple medicines which can act on these things. The first and foremost, the age-old one is aspirin, the COX inhibitor. Then we have the dual antiplatelets such as the clopidogrel, prasugrel, and ticagrelor. Recent studies have come up with antithrombotics, that is rivaroxaban, this factor 10A inhibitors. If you go into the evidence, aspirin is the one which can prevent coronary disease and with lowest risk of bleeding, but especially in diabetics due to endothelial dysfunction, dysregulated platelets and platelets inhibition, probably aspirin might not be so much effective. Capri study shows that clopidogrel is as good and probably as effective as aspirin, probably, but not much with increased bleeding. So probably clopidogrel can be used in alternative in some set of patients. But patients who underwent angioplasty, probably who has done angioplasty now is unstable. On those patients, dual antiplatelets are definitely recommended. Third thing, a new study which has showed that probably aspirin with low dose rivaroxaban has an ability to decrease the cardiovascular risk, but it's some increased risk of bleeding. So probably with some subset of patients who are with high risk and who are having probably recurrent ischemic events, we can try these patients with both dual antiplatelet as an antithrombotic, that is aspirin low dose with low dose rivaroxaban. So aspirin is 1A. Similarly, prolonged day with aspirin P2 is already 2A to even these things, and aspirin plus rivaroxaban also a 2A 2B with a level of evidence B. A recent study also showed that probably for some patients who have some dyspepsia or GA bleeds, or probably whom aspirin cannot be used, probably monotherapy with ticagrelor was also shown to be equally effective, but yeah, the bleeding risk will be slightly high when we compare to isolated aspirin alone. So coming to chronic coronary system management, in with patients with stable angina diabetes, symptoms of ischemia may be atypical and are often underdiagnosed. So probably we should have a broad view, and probably we should investigate them detailedly regarding their clinical findings, probably presenting symptoms, risk factors, probably evaluate them detailedly in the cardiac, and probably look for cardiac markers to see whether this is symptoms are cardiac related or non-cardiac related. However, in patient, the development of angina symptoms associated with decreased physical function and reduced disease-specific quality of life. So, in the symptomatic management of stable angina, the goal is to confirm the diagnosis of AD, exclude high-risk disease, and reduce symptoms through optimum medical therapy with or without medical revascularization if needed. So, how do you assess them for their risk stratification? So, there are many ways. We go by either functional versus anatomic. So, functional is looking for inducible ischemia, either it could be through treadmill or could be stress thallium or various other modalities. Anatomical is by looking for a non-invasive itself. We have a coronary CT angiogram where we can assess the anatomies. So there were few studies. One study was called HEART30 where it was compared between anatomical functions. So people were grouped into two groups. One group, they underwent a CT coronary angiogram, went stress thallium. So they were followed. What they have seen is that those who underwent CT coronary angiogram, probably the mortality, morbidity and worsening of symptoms were less compared to those underway functional assessment. So it was attributed that probably the CT angiogram had also diagnosed non-obstructive lesions, 30, 40, 50% lesions, or probably some amount of unstable plaques. And those patients were better monitored, better treated, and better observed, so that probably they have less these things than the functional. But if you all see that overall CT angiogram might have slightly beneficial when compared to functional testing, but we also should understand the cost included and the radiation, and also the probably we can't do it, keep on repeating it frequently. Probably for initial patients or patients are at high risk, probably this might help us in risk stratification. So coming to the basic treatment of CCS. So anginal management is a basic and the most important treatment of these things. The classical treatment for angina is in what we call as a diamond approach, where you have a couple of medicines starting with the beta blockers, the age-old one. Then we have calcium channel blockers. Then we have diltiazem, that's a non-hypertensive calcium channel blockers. Then we have nitrates, nicorandil, ivabradine, ranolazine, trimetazine. So what we see is that the green lines are the things which can be used together and are beneficial when added together. So nicorandil, nitrates with beta blockers with calcium channel blockers. Probably for these things are these things. Red things are which never should be used together, beta blockers and diltiazem. Similarly, ivabradine and diltiazem. So, and the blue things are probably similar effects, but probably have an advantages. So, this is a classical anginal management for most of the subsets. What we have to understand is that probably when we consider CCS in a diabetic patients, we need to understand that there are some limitations which we need to consider. So, beta blockers, especially in diabetic patients, should be avoided or probably used in lesser intensity for those patients who have a recurrent hypoglycemia, because beta blockers have not to have hypoglycemia. Second thing, most of the nitrates in nicorandil have headaches and they have some symptoms which probably limit the usage of things. Ivabradine trimetazidone has not shown much, there is not much data to say that there is definite benefit to use these things in patients with diabetes with chronic coronary syndromes. Yeah, but there is definite data on beta blockers, calcium channel blockers, nitrates, and ranolazine. So ranolazine, we have to understand, is basically it inhibits the late sodium channel, probably decreasing the sodium as well as calcium overload. So usually what we see this channel being overactive when you have hypoxemia, ischemia, heart failure, atrial fibrillation, and also sometimes in some inherited conditions. So this inhibits it, probably decreases the calcium overload and probably decreases the ischemia and also improves the metabolism. So when we consider diabetics, chronic coronary syndromes, no anti-anginal medicines reduce morbidity or mortality in stable CID and have similar impact on the reducing angina. Beta blockers, we prefer vasodilator, carvedilol, labetalol, or Navicart. Calcium, avoid non-hereditary patients with LV dysfunction or with beta blockers. Long-acting nitrates have been our long working hours. Usually what we have to understand is that long-term use of nitrates can cause tolerance, and probably timing the medicines is very important, because they might develop tolerance and also endothelial dysfunction. Ranolazine has a newer one. The advantage with ranolazine is it has no hemodynamic effects, and also in diabetic patients it has shown to have some reduction in the HbA1c. So for a diabetic patient whose HbA1c is not controlled and who has chronic coronary syndromes, adding ranolazine will have a dual benefit. Probably it will reduce his HbA1c levels to some extent and also will have anti-anginal effects in these sort of patients. And mostly it doesn't have any hemodynamic compromise, unlike the nitrates, beta blockers, and calcium channel blockers. And also these do not worsen the hypoglycemia. So now we have discussed what are the traditional factors which have to be controlled and how they have to be controlled and how angina has to be managed. Now, is there really a role for revascularization? So, OMT, that is optimal medical therapy with risk modification, remains the foundation of management in patients with diabetes and coronary heart disease. As coronary anatomic burden and complexity increase, particularly among those with large ischemic burden or frequent angina, the benefit of revascularization combined with OMT becomes manifest. What we have to understand is that diabetic subset have a very, very bad disease. Usually, they have extensive disease where revascularization might be difficult or might be incomplete, or probably sometimes is not possible. So in those sort of things, so most of the studies which have checked on revascularization, the data is not very interesting or not positive. So both surgical percutaneous outcomes are impaired in the setting of diabetes with an increased risk of adverse procedural events and of long-term developmental progression and restenosis. The relative benefit and risk of each revascularization strategy vary by the extent and complexity of CAD and the patient's underlying comorbid state. Therefore, individualization is necessary. Revascularization is not a strict no-no. With improving techniques and improving technology, probably we are able to revascularize. So, patient who has a multivessel CAD, left main disease and complex coronary arteries, most of the studies says that CABG has shown definite benefit when we consider complex PCI. And the benefit was noted only if intermammary artery was used and also only if complete revascularization was used. What we have to understand is that most of the benefit of CABG versus PCI was on two accounts. One, recurrent restenosis or recurrent infarcts was less with CABG when compared with PCI. So that showed a greater benefit for CABG with PCI. And third thing, most of the CABGs, the revascularization was complete. So most of the territories were revascularized. So the patient had future less angina or less recurrence of symptoms. So when we consider complete revascularization and probably restenosis, CABG has shown that it is always benefitable when comparable to PCI, especially in patients who are diabetic and who are having chronic coronary syndromes. But the thing is that with now newer technologies, probably we are able to achieve more revascularization, better stents, better medications, better follow-ups. PCI is not very much behind CABGs in these settings. Probably future studies down the line probably might show that in some subset of these patients, PCI might have also still a role to play. So, what are the characteristics which favors PCI? Presence of severe comorbidity, not adequate refractory scores, advanced age, frailty, reduced life expectancy, restricted mobility, and conditions that affect the rehabilitation process. And syntax score of less than 22, and anatomy wherein the revascularization is not going to be complete with CABGs, some chest deformities, scoliosis, chest radiation, lung issues. Similarly, what favors CABGs? Long-standing diabetes, low EFs, contraindications to dual antiplatelet because high risk of bleeding is there. Recurrent instant restenosis was already noted in these patients. Syntax more than 32 and adequate revascularization by PCI is not enough. So these are all will favor the CABG side. What the thing most important is that simply correcting the diabetes, correcting the cholesterol, correcting the lipids, and probably putting them on adequate anti-anginals and probably if needed revascularization, that doesn't end for the chronic coronary syndromes. Cardiac rehabilitation, which is the most neglected part in India, needs a major role and probably push up for these sort of patients. Because cardiac rehabilitation is a very vast thing, probably it involves most of the aspects which needs to be covered. So the core concepts are patient assessment, nutritional counseling, weight management, blood pressure management, lipid management, diabetic management, tobacco cessation. The three things which needs to be reassured: psychosocial management, physical activity counseling, and exercise training. What most studies have said is that probably supportive or probably monitored exercise regimens and probably helping them to manage the psychosocial stress have shown a lot of benefit, especially in diabetics with chronic coronary syndromes. So briefly to summarize, stable CAD, which is now called as chronic coronary syndromes, the four pillars are antiplatelets or antithrombotics. It could be aspirin, it could be clopidogrel, it could be dual antiplatelets, or it could be antiplatelet with anticoagulant. Then proper hyperglycemic control, metformin, SGLT2, GLP-1, thiazolidines have a role, and other drugs along with it. Statins, high intensity statins for adequate control of LDL, and also, especially being a diabetic, triglycerides also need to be given importance and has to be controlled. BP control, and the patient is symptomatic, going for adequate anti-angina therapy. If the symptoms are still not controlled with anti-angina, going for revascularization in selective subset of patients. Thank you.
Many of the diabetic patients presenting with ACS. So there is something lacking either the patients or even in the cardiologist, what I feel. So with your practical experience, how we can catch these patients at the earliest? You suggest every patient of diabetic to go for the aggressive cardiac workup or you think some parameters will be taken care so that we can pick up early those kind of patients and we can prevent the future ACS as well as they can manage properly this stable because most of the patients are asymptomatic and they just come to the routine follow.
My practice, I usually follow three entities. So we try to see the patient in total. Most of them are symptomatic, so there is no point in looking for symptoms. So we go for their risk factors. So classical age, male, diabetes, the traditional risk factors. Beyond the risk factors, probably we need to consider what they do. So we will try to assess the risk factors in terms of stress, the physical activity, how food control is there. Probably go into a little bit of their family histories. That would be one thing. Then probably investigation of their how adequate is the sugar control, how are the lipids doing. Probably each component of the dyslipidemia has to be taken into account, and probably blood pressure. And apart from that, probably we need to have some functional assessment. I would prefer to do probably patients who are beyond 3 to 4 years of diabetic. Serial follow-ups with either probably the treadmill would be the most simpler way for us and least cost and least effective ways. And sometimes what I've seen is that probably HSCRPs we have been assessing recently to assess the probably the inflammation or the psychosocial stress, probably considering the inflammation or the infections, ruling out those things. These will help us to see which probably these are not a very clear-cut demarcations, but this will help us to isolate patients who are probably at least moderate to high risk and probably keep them on a more frequent follow-up with adequate control of most of the things. Yeah, treadmill has its own inherent deficiencies, but probably when we compare our clinical assessment with other lab parameters and its risk profile, probably we can close it down to around 80 to 90% might be enough. And third thing, probably misdiagnosed. Probably most of them will be evaluated for gastritis or for dyspeptic disorders or for some other things. Especially obese patients, we can't differentiate between whether it's due to the lifestyle or habitus or these things. Probably there are no clear cut, but probably when you combine all those things, three of these things, probably we might help us to differentiate these things. Role for troponins and antipro maybe is still not very clear because I think probably that adds a lot of cost to the patient. But yeah, probably yearly treadmill tests and probably 6 months monitoring their lipids, monitoring their HbA1c levels and assessing their stress levels. And probably most important thing is that educating them on the importance of diet, adequate sleep, weight loss, apart from the physical activity. If these four things have to be inculcated, especially in diabetics who are starting very young. And second thing, probably removing the lot of people are afraid to start medicines early, consider diabetes, hypertensive or cholesterol, because most of them they feel that okay, once we start, it's for lifetime. Probably we need to spend time with these patients, educate them that yeah, starting early might prevent most of the things, and probably yeah, if they modify their lifestyle enough, probably some might people be off medicines for long times. These 3-4 things would be very important, especially considering the very bad disease we are seeing in younger populations.
Regarding one more special subject for female population, what we see, those are hypothyroid, hypertensive, diabetes. And in these patients, it's become very difficult for treatment test and all those very inconclusive. Okay. So, how do you approach these kind of patients?
Alternatively, what we can do is that probably we can plan stress echoes or something which are relatively stable. But again, probably dopamine stress echo has own inherent problems, especially with arrhythmias and all those things. Apart from treadmill test, probably assessing their clinical symptoms would be more. But I think females, especially middle-aged, bringing them to the hospitals or bringing them for checkups is the most challenge, and probably making them do investigations or come for regular follow-ups that would be most follow-ups. And most of these patients end up with bad disease, insalvageable, and with lot of morbidity and mortality.
For type 1 diabetes mellitus, what is the monitoring for the cardiac status?
Sir, type 1 probably we are not so much these things, sir, but beyond a point of 10 to 15 years, we definitely the problems would start with it. But most of the times what now, when we combine diabetes to the psychosocial stress which is less, probably they might also be in the present scenario after. When they reach their 20s, 30s, they should be the thing, probably they should be monitored regularly nowadays.
Yeah, same question I wanted to ask. That, sir.
So probably, sir, previously we were not worried until the 30s or 40s, but now with the changing lifestyles, with even we are having probably not a significant but good numbers of type 1 diabetes were presenting early with coronary disease. Not so common as type 2 diabetes mellitus, because type 1 has more or less has been a microvascular rather than macrovascular issues. But I think so with the changing lifestyles and the change in these things, probably ideally the thing was that beyond 15 years, what diabetes, for the type 2 diabetes we were looking at 5 years. We used to look for type 1 diabetes beyond 15 years probably, but it might be slightly early. But I think so we need to look at data.
Sir, I just want to ask that, what do you think about these novel risk factors? Because we have not yet proven otherwise that this is a strong risk factor and also. But nowadays, the incidence of coronary disease is also increasing in young individuals. Few individuals, because of some atypical pain, they got evaluated with sometimes CTCAG. I've seen some individuals in 30s coming with triple vessel disease. They have some novel risk factors. Sometimes they are smoking. Commonly, they say other risk factors also.
What I consider it as these are novel risk factors, we say that, but probably if you say I forgot the study, inter-heart registry or what. So that was probably 15 years back. 15 years back. It has said that psychosocial stress corresponds to 33% of your coronary risk. One third. So that was if we consider it as nearly equivalent to diabetes and hypertension. So it was there, sir. It was not there. But probably what we are seeing in the last post-COVID. So again, the comes has COVID created anything or these things. This again, it's a debatable. What I feel is that my practice, COVID has done nothing, not done anything actively, yeah, passively. People's lifestyle have changed post-COVID. The stress levels have increased. Physical activity has come down drastically, especially if you consider the IT sector. The food habits bad. So probably these are the few conditions. I will say psychosocial stress. So psychosocial stress, when added with dietary and lack of physical activity, is the now taking time bomb. This is going to, because these three again would cause diabetes, would cause hypertension, would cause dyslipidemia. So this has to be addressed, because I think so. Previously, a ratio of young MIs was hardly probably 5% or now we are seeing easily around 20 to 30% young MIs. Easily 20 to 30%. The things might be a little bit higher also, because some might because in these patients most of them might not reach the hospitals also. And when we take it a primary, if it's elderly person, we are like comfortable, but if it's younger person, we are afraid, because it's going to be a triple vessel disease, difficult, convincing the patient, outcomes and everything is going to be bad. Yeah, novel risk factors, psychosocial stress, physical activity, dietary. And dietary is again, the three components have to be considered, the right thing, the right quantity and the right time. And fourth thing is that probably the recent studies regarding adequate sleep. Sleep minimum 6 to 8 hours is very, very important, needs to be stressed. Probably these four, I think if need, are the novel risk factors which we should consider.
Yes. Yeah. So one more thing, because one side we are thinking about reduction of antiplatelets to consider bearing risk. Even post PCA patients also, we say sometimes in very high risk, say 1 month, 3 months, sometimes 6 months we stop dual antiplatelets and continue with single antiplatelet and CADs. The other way, in other aspects, to reduce the ischemic risk again, you want single or double, sometimes even triple therapy for short durations. So, what would you suggest us all that how to reduce or manage bleeding in these individuals? Because I've seen few patients started on dual antiplatelets, probably not monitored or what, and came with probably ISIC leads or pleural hemorrhage. Some individuals with single antiplatelet, they come with severe anemias.
Aspirin is especially notorious, even though it has least bleeding effects. Aspirin, especially when used dual or single, is known to cause anemia silently. I mean, patient suddenly comes without. We look for it. They don't have major bleeders or any of these things. Probably what we're thinking is that uh, dual antiplatelets in an Indian subset, most of the times we can't get away for less than 1 year, unless until they are very simple lesions, which are a rarity as of now, because we end up, yeah, probably there, probably open heart surgery, bypass surgeries, the advantages would be slightly more because the patients might be on less antiplatelets. But again, in the CABG also we are seeing too much of restenosis, graft blockages, again the same thing. Yeah, probably it has to be individualized patient to patient, depending upon his comorbidities as well as the lesions or whatever it is, his anatomy. Third thing, probably having a healthy dietary patterns will also help in these patients. Probably again, too much concentrating on the medicines and not targeting the lifestyle, including the dietary patterns, will also help, will also are causing most of these things. Dual antiplatelets for 1 year, and probably if a patient is a non-GA bleed or anything, single antiplatelet clopidogrel is also has been effective. Sometimes newer studies have said that probably ticagrelor 60 mg twice daily would be slightly better for OPG or longer. You can't give aspirin and those things, but again, it comes at a cost.
So all of that will take about 20
We-
very good.
they're good.
Stop it.
Especially what you have seen is that we stop aspirin and continue them with ticagrelors in some patients. The anemia part at least is settling down. But it's, I mean, it's an early stage to say so.
So one last question. For all of us again, when do you suggest that a general physician or general medicine physician will see here who can generally can manage, but at what time do you suggest, say ACS, acute coronary syndrome, definitely refer to a consultant or international cardiologist, or when in a phase of a CCS or chronic coronary syndrome, when do you want the physician to refer to an interventional cardiologist?
Basically, first option would be when he starts having anginal symptoms, typical symptoms. That to the point, he should be referred to a cardiologist, because okay, at that point probably we need to have a much more modification which is needed, or else the other patients probably who are long-standing diabetes, even though they are asymptomatic. Anything, suppose multiple risk factors, family history is strong, he has other end organ damage, proteinuria is there, microalbuminuria is there, some retinopathy, then I think these are the patients who needs to be evaluated compulsorily for this, even though they are asymptomatic. Anybody who is beyond 10 years of diabetic should be compulsorily evaluated. 5 years and more with other target organ damage, or who are at high subset, where the dyslipidemia is very bad, sugar control is very bad. So they need to be assessed a little bit early.